All right, well, it's 7 o'clock, everyone. Nice to have you with us. Welcome. I'm coming to you, as you can see from the background, from sunny Wisconsin. We are joined by our board members and our panel today, along with our featured speaker, to talk about cardiovascular health. So tonight, we're going to get to the heart of the matter and talk a little bit about cardiovascular wellness, the risks associated with cardiovascular disease, and things that we can do to be preventative. So before we introduce our featured speaker, I'd like to introduce you to the board members of the International Holistic Health Alliance. Our goal with this association is to make sure that we are bringing education to the masses. So we are going to introduce our board member, Jeff Essen. If you could just raise your hand. Right. Jeff Essen is an accomplished naturopathic doctor, holistic healthcare practitioner, a certified gluten practitioner, and a nutritional therapy practitioner. He's been in practice since 2000. He's the founder of Whole Life Clinic PMA in Rosemount, Minnesota, where he practices naturopathic medicine, nutritional therapy, and uses numerous biofeedback and therapy devices to aid patients in reaching their health goals. He specializes in autoimmune disease, digestive issues, and functional hormone support. Dr. Abdel Al-Khalouf, if you could go ahead and raise your hand. Dr. Abdel is from Southern Florida. He has a PhD in nursing science, a master's of science in acute care, and he spent years teaching as a university medical adjunct professor until 2013, when he decided to branch out into the natural health world. Through education and product development, he's been making his mark ever since. He is the co-owner of FGF USA, which stands for Feel Good Forever. That is a supplement company, if you are not aware of. Starla Weichman, if you could raise your hand. She has been in the natural health industry for over 13 years. She is a board certified holistic health practitioner, constantly attending webinars and seminars to further her knowledge. She owns and operates Be Healthy Naturally in Ottumwa, Iowa, where she specializes in biofeedback testing as well as PEMF therapy. She is also the founder of the IHHA. So I am Tracy Abraham. I'll be your host this evening. I as well am a board certified holistic health practitioner. I specialize in bioenergetic screenings as well as Lyme disease. And I own Amplify Health and Wellness here in Appleton, Wisconsin. So we are really happy to welcome you to be with us this evening. At this point, I'd like to introduce you to our featured speaker, Dee Dorsett. She lives in Southeast Iowa, and she received her bachelor's in nursing at the University of Iowa in the late 1980s. And then later in life, she obtained her master's in nursing and family nurse practitioner certification in 2013. For the last 30 years, she has specialized in cardiovascular care, working in cardiac rehabilitation, developing lipid and prevention clinics. She's done public teaching and managing a cardiovascular clinic. As a nurse practitioner for Mercy One Iowa Heart Center, she spent the last decade treating coronary artery and peripheral artery disease, along with heart failure and electrophysiological problems. Dee is passionate about educating her patients about lifestyle and prevention measures, and she began transitioning to the integrative medicine space a few years ago when she opened her clinic called Intentional Health Clinic, with one arm of that being Eye Vitality Infusions in Ottumwa. So Dee, we are so excited to have you with us today. With that in mind, the virtual floor is yours.
Well, thank you. I really appreciate you having me. I do love to talk about this topic. I've worked with patients a lot. I've seen some really nice benefits and nice things that have occurred. And I just really love the topic. So, but thanks for having me. And I am going to share my screen and show you my slides. Oops, that didn't happen. There. Can you see them?
It's perfect. Thank you.
Okay, thanks. Let me get rid of you guys. All right, so I chose this title, The Heart of the Matter, Cardiovascular Wellness, because basically I had all those years in cardiology. I was treating people, but I would treat them after they had their event, basically. And if I wanted to talk about prevention and wellness and that sort of thing, I had to try to squeeze that into like 5 minutes. I did open up a prevention clinic that we had in Iowa at Iowa Heart, and that clinic also was it was great to do, but I still didn't have enough time because I still had 20 minutes with the patient. So anyway, I love being able to make this transition. The way I kind of view my practice now is that it's more integrative, although I'm not really prescribing a lot of medicines right now. But if I had to, I could, but that would only be an important, at an important time, like a really high blood pressure or something like that. So I really like more, what can we do to help prevent heart disease from progressing? So I'm going to actually do a little quick anatomy and physiology. Some of you may already know this. Here, let me get there. All right, some of you already may know this, but I think it's really important to just kind of go over it very quickly to understand kind of how, like if you're looking at blood pressure, why does blood pressure do that? Or why do I have these symptoms, that kind of thing. If you kind of understand it, because it's complex, but it's also very simple. So if you think of the heart, the heart is a pump. It's got a job. It's like the car engine. And so I'm going to use my cursor. The right side of the heart, excuse me, receives blood from the rest of the body, and it comes in through veins. So veins are historically blue. That's just because they're not highly oxygenated. The blood's not highly oxygenated. It's taking the waste products and it's already delivered oxygen to the cells. So when the blood comes back to the heart, it comes in through the right heart. And that side of the heart, then its job is to send the blood to the lungs. And when it does that, so I'm going to compare and contrast the right side to the left side. When it sends the blood into the lungs, that's the only place it has to send it. And then after it's in the lungs, you're going to, you're breathing, you're going to get more oxygen into the blood, and you're going to expire or breathe out wastes. And so, so after it goes into the lungs, it then comes back to the left side of the heart, which also has 2 chambers. Each side has 2 chambers where the blood flows through valves. And then the left side of the heart, it sends the blood to the rest of the body. And so the thing about the fact that the left side of the heart does that, it's got the biggest job. So not only does it have to send it to the arms and the legs, it's got to go all the way up to the brain against gravity and that sort of thing. So if you have a client or a patient that's coming in to see you and they're telling you about some of their problems, if they talk about heart failure, probably 99% of the time they're talking about the left side of the heart not doing a very good job at dealing with the fluid content that's in all of these arteries and veins. And so the heart is like that car engine. The arteries and the veins are like the pipes. So if you think about, like, if that all has to be working, how would it break down? Well, one would be the pump doesn't work, or it's weak, or it has a heart attack and part of the heart doesn't work right, or maybe the pipes get clogged. And the other possibility would be structure. So sometimes valves wear out. Sometimes people are genetically predisposed to that. And sometimes the electrical conduction system in the heart doesn't work either. So maybe somebody might have a rhythm issue or something like that. So I'm just going over this briefly, just to sort of give you an idea. The heart has been extensively researched. I mean, it's one of the most researched parts of your body, along with the brain. And so there's lots of information out there that a person could read, look at, or whatever. But the most important thing is that I wanted you to know today is just sort of the basics of what the cardiovascular system is. So then I also included several slides that talk about risk for heart disease. This is like hot off the presses. It hasn't really changed a ton over the years, but it has changed in some of the risk factors have changed in importance, I would say. I'm not going to read all of this, but the thing that I want you to take away from this is whether it's you or it's someone else that's coming in with vague symptoms and you're trying to think to yourself, well, what do I think the risk is that they maybe have something going on in their heart? And then if that's the case, what do I do about it? So as far as age, way back in Vietnam, they had research studies that actually even showed that some of the men that had died over in Vietnam, autopsies showed that they already had some coronary artery disease occurring over the age of 30. And so that's why this risk factor, I mean, it's 35, it's pretty young. We didn't used to really talk about it that way, but I have seen enough. And also we've heard of people that have had heart attacks even in their 20s. Some of that is very much lifestyle. There's a lot of inflammation. I'll talk about that in a minute. And, 50% of heart attacks occur with less than a 50% blockage in the heart artery, in a heart artery. That's a lot. And so one of the things that was frustrating to me when I was actually treating patients was because one mantra is, we can't tell you if you're going to have a heart attack, we can't prevent it. We can't predict it and we can't prevent it. And I really hated saying that. And when I would look at the guidelines also, there was always, give this statin, give this statin. It got to the point where almost everybody's getting one. And then the other thing is that there would be, along with all the other prevention things, there would be this one little spot clear at the bottom that said, oh, and by the way, maybe inflammation's a thing. But it's not on a regular basis being addressed or looked at, or even like the why behind why you would have inflammation. So anyway, that's why these younger numbers, I think, because I think we have a lot more of it now. And then gender, they still say men are have more risk compared to women, but I saw tons of women. So I think that there's more than that. Ethnicity, there's a list here. Family history, this is really important because these numbers have changed a little bit. So if you're looking at your family history, and when I talk about family history, I'm talking about first degree relatives, premature, if you have someone with premature heart disease, that would be anyone under the age of 50. But what if you don't have somebody that's under the age of 50? Well, maybe you don't have that, but you also have a lot of family members that have heart disease. We then look at the male ones because we look at both male and female, but we'll pull out the male ones, say a father or a brother. You start stacking on risk from each family member. And then also, so that would be under an event, a heart attack under the age of 55, or a mother or sister diagnosed under the age of 65. And those are considered risk factors. So, and I'm talking about for cardiovascular disease. When we say cardiovascular, we're talking about the heart and then also the arteries. So that's why I showed that photo before this one. That's because also you can have disease. If you have disease in the arteries one place, you often have disease elsewhere. And we'll also talk about how that occurs. Here's another one. I really am focusing on hypertension a lot during this presentation, just because it's very, very, very prevalent. You'll see on the slides, let's see, I need to get rid of some of these. I can't see my whole slide. Let me get back there. Sorry about that. But only 54% of patients actually have their blood pressure very well controlled. And the other thing it talks about here, which I appreciate it talks about how hypertension creates both the oxidative and the mechanical stress. You can imagine your arteries are made to get bigger if you need to lower your blood pressure, because your body always wants to be in a steady state. So whether it's how much potassium you have, how much sugar you have in your blood, what your blood pressure is, your body's adjusting to whatever's thrown at it all the time. And so the arteries, they're very important to regulate the blood pressure. So if you're having low blood pressure, they'll tighten up, and vice versa. So the thing about it is the mechanical stress. This is really important because if you're running too high of a blood pressure chronically, that is worse than if you have a higher blood pressure temporarily. So an example of that would be like if you exercise pretty hard, you're going to get a higher blood pressure, but it's temporary. If you're under a lot of stress, you might have a higher blood pressure, but hopefully then the stress comes down. Chronic stress, though, can produce chronic hypertension. And that's where you have more chance of having like damage inside your artery walls. So you just think about like if you have a high pressure inside the artery walls, they're a muscular layer, and then you have an inside lining. And so as you're having a high blood pressure, it can create stress, like a shearing kind of stress inside the artery. And then that can cause some inflammation, and also your cholesterol, which has a lot of properties in your body. But one of them is for it to come to any area that has injury that's like inside artery walls, to actually kind of band-aid it if it has inflammation. And in that case, then you have your artery, and I've got a photo of this in a second, I'll show you. But it will, as it comes to Band-Aid, it can get trapped in between the lining and the muscle layer of the artery. And that's what happens. That's called soft plaque. If you have it in your arteries for a long time, then what happens is your body deals with it in such a way that it causes it to become calcified. And that's called stable heart disease. Because once it's calcified, there's less chance it's going to break off and then go downstream to a smaller artery and create a blockage. So, so that's that. If we look at hyperlipidemia, this is one thing that I'm going to be honest, because I was still practicing cardiology in medical last year. So I will be honest as far as, and hopefully, I keep doing this, sorry. I think I'm trigger happy. Hopefully, like Abed and some other people will chime in if they have information regarding proper treatment. I know that I've prescribed statins for a long time. And as far as the best way to deal with this, I will just say, I know we need cholesterol, and I've questioned what medical is saying. And so I'm just going to not be definite on this today, other than I'll talk about triglycerides. For diabetes, this is a thing that is obvious. You probably know way more people than you used to know that have diabetes. This is definitely, a lot of it is related to lifestyle. We'll talk about lifestyle in a second, but I will say that at the bottom of this slide, you can see that the A1C, that's just to, if you don't know what that is, A1C is a measure of, basically, it gives you an idea of what your blood sugars have been over the last 3 years, or that would be nice, last 3 months. So the higher it is, the worse it is for you. Your blood sugar has a big effect, an inflammatory effect against the inside of your artery walls, and it can cause your arteries to be dysfunctional, basically, if it's not dealt with. We'll talk more about like the type of diet that causes that, and what kinds of things that do that. But the measurement right now is A1C, or a random fasting blood sugar. And I think probably what's most used for diagnosis is A1C. So this just lets you know, like the fact that the higher the A1C is, the higher the risk for heart disease. Obesity, 69% of the adults in the United States are overweight or obese. I'll talk about what the measurement is of that, and then we can also talk about diet. Smoking, smokers have 2 times the risk of coronary artery disease, and ex-smokers still have an increased risk. And that's among the patients 60 years old. But I highlighted the non-smokers because a lot of times people think they're fine. So we're not fine if we're exposed to secondhand smoke. As far as poor diet goes, what I thought was interesting here is that there's been a shift, because we've always in cardiology talked about saturated fats as being evil. And I mean, they're not beautiful, but they're not as bad as the trans fats. And the trans fats are associated with a higher risk of coronary disease. And I think that we're going to find, a place, we definitely are finding a place for the saturated fats. This also talks about soft drinks and sweetened beverages being associated with a higher risk of heart attack. So I'll let you read that later. Sedentary lifestyle, basically a sedentary lifestyle is of someone who's not doing it the recommended amount of exercise. We'll talk about that. People who, what did I say here? People who exercise die less often. I don't think I meant to say that. People who don't exercise, well, they have a higher, there's a negative effect if you don't exercise. I'm not sure what I meant by that. So modifiable risk factors for a coronary artery disease. What I did here is I wrote them down so that, they're the risk factors of your family, who your family is, what your genetic predisposition is, what your race is. All of that you can't really change, but these are things you can change. So what I did was I looked at what the typical definitions are. Current cigarette smoking, secondhand smoking, of course, stopping smoking. Here's an idea. Some people don't, they don't want to quit cold turkey. I had a patient one time tell me that what he did was he looked at how much am I smoking in a week? And if it was 10 cigarettes a day, then what he did was he took 7 Ziploc bags, put 10 cigarettes in each. Of course, we'd like people to be done now, but the reality is that it's very difficult to make a big lifestyle change like that. So I am for actually this method. And then what he would do is each week after that, he would put in less cigarettes. So like the next week would be 9, the week after that would be 8. And then that was just one way that he could slowly remove that from his life. And I've shared that with a lot of people and they've really liked it and it's been helpful. For diabetes, here's the A1C. That 5.7 is the breaking point where you're like, okay, you're pre-diabetic. But optimal recommendation really is 5.2 to 5.3, and under 5, you have so much less of a risk of heart disease. So I'll talk about that also in a minute. High triglycerides, that's a sign of insulin insensitivity. So I want to talk about that really quick. If there's anybody here that doesn't quite understand what that is. What that is when a person eats a carbohydrate, there are different kinds. You've probably heard about maybe glycemic index. I think this is a huge root of the cause of, I didn't say that right, but the root of our problems, a lot of our problems with inflammation. This is one of the things. So basically, if you eat something that easily breaks down, and some of it is like if it's food that it takes a while for you to chew, that means it has a lower glycemic index. So in other words, it breaks down slower. So an example of that would be like nuts, or like when you talk about glycemic index, like the berries are the ones that are often like the red and the blue. Those are often low glycemic, and therefore it doesn't cause a high sugar spike in your blood. But if you eat a banana, or if you eat Rice Krispies or Cheerios, they always said Cheerios were good for the heart, but really they're not. They don't have any cholesterol. That's the only thing they were basing that on. But if you think about foods that are high glycemic, in other words, they create a high blood sugar in the blood. Those are foods that basically dissolve in your mouth just about. So if you think about sticking a Cheerio in your mouth, that would be an example of a high glycemic food. Now, do you have to never eat those? I usually tell my patients, you can eat a banana, but you don't want to make all of your carbohydrates come from that. So if your triglycerides are high and you have a lot of sugar in your body, and every time you have a high, so anytime you eat like a high glycemic carbohydrate, the sugar rises quickly. Your pancreas says, crap, I need to bring that down, because your body is always trying to keep level states of things. And so when it does that, it's really a stress. It's a very stressful thing to the pancreas to have to do that. Well, it makes a whole bunch of insulin to try to bring that sugar down. And the role of insulin, it's a hormone, it binds with the sugar, it takes it to the muscle cells and it says, hey, do you need this? Do you need this? And if you're not exercising right, then the muscle cells go, no, man, I don't need it. And so then the body has to do something with it. So it takes the sugar, it converts it to triglycerides, and that's a source of fuel to be stored later, and it's stored as fat. So what happens is over time, then the muscle cells, and there are other things that occur as well, but in a nutshell, the muscle cells just are like, no, we don't want to hear about this insulin. We are not going to respond. So basically that's kind of the deal. So you really want to make sure that you're doing the right thing as far as your carbohydrates go. So there's a moderate glycemic carbohydrate level as well, and you usually can find this stuff online. Obesity is considered a BMI over 24.9. Of course, this isn't the best way to determine health and your body conditioning and that kind of thing, but it is something that medically has been used, and it's used for diagnosis. So the BMI being taking your height and your weight, putting it together in a chart, and then someone decided this is obesity after 24.9. So there's a calculator if somebody wants to use that, if maybe you have a client in your office and they want to know something like that. Physical inactivity and low fitness, walking 150 minutes per week is the recommendation. And part of the reason why they're starting to go away from the really intense cardio, which still, it's not that you can't do that, but part of that is because that also is like increased cortisol. And if you study that, you will find different people saying different things about that. But the bottom line is get in 150. If you are a high intense cardio person, or you like to do the interval training, that would be 75 minutes per week if it's a moderate intensity. And then everybody should add resistance training of one sort or not, or one kind or not, or another. And that would be like Pilates or yoga, or even lifting weights if you know how to do that. I'm a big, huge proponent of this. And one example I'll give you is I had a couple of patients that were 94, and they did calisthenics every day. And they'd even like show me in the exam room. I'd walk in and they're doing, push-ups. And so I just love that, because what it does is, as we get older, and we may live longer if the biohackers are right, we may live past 100. People are doing it already, but I think that you'd rather be walking into the decade of the 90s than crawling. And the best way to do that is to exercise and to eat, keep your protein up and that kind of thing, keep your muscles. As far as diets, I have been researching this for 3 years, and I haven't come across the one thing. If people want to lose weight, almost any diet works, as long as they're decreasing calories, or in some cases they need to eat more, and because maybe they're starving themselves and they didn't realize it. The other thing is the protein's really important. I'm getting very interested in the paleo ketogenic diet. I don't know if anybody's heard about that, but I will say there are some people in Hungary that are actually experimenting with that. So if you have any interest, you could take a look at that. That's paleo diet and keto together. And I don't even know what it is, because I have to pay them to be their patient to find out. But anyway, some people are having some good success with keto. And if you look at some of the gurus within cardiology that are on the natural side, some will really recommend that, or this carnivore for like autoimmune diseases. But also then on the flip side of that, you'll get another cardiologist will say, no way, plant-based. Cardiology in medicine will say Mediterranean diet. I think low glycemic is really important, as long as you still are getting your carbs, but you're getting the right kind of carbs. And then in general, like cardiac rehab would say, 40% of your calories that you take in, and you can do like you can figure out how many calories you should actually get and go a little bit less if you're trying to lose weight. You can figure that out. And then 40% of that would be from protein and 30% from fat. And then that's the good fats, and then 30% of low glycemic carbohydrates. And then I think, I can't see this on my slide, but it says that in general, if you need to lose weight and you lose 20 pounds, then that can result in a 10-point decrease in the top number of your blood pressure, which is called the systolic blood pressure. So I added this slide just because I'm so passionate about this. And some people have blood pressure cuffs in their clinics and at home. And so one of the most important things is that people take their blood pressure properly. So when I was in school, when I got my master's degree, I did a research project. I started studying blood pressure. And then of course I immediately regretted it when I saw there were over 3,000 studies that I had to review. I didn't really review them all, but don't tell my professors. But when I did, basically what I learned was that in general, there had been a lot of studies more recently, like 20 years, over the last 20 to 30 years, that found that providers, medical people, anyone that did blood pressures didn't really know how to do it properly. And my biggest concern was that people were getting put on medicine when they didn't need to be. Because when you look at blood pressure recommendations, they're pretty narrow. So anyway, I created a chart. I don't have the chart here. If anybody wants it, just ask me and I can get it for you. But basically it talks about all the different things that are important. I've got that on the next slide. There's basically, some people may ask, like, manual cuff, electronic, what's the best one? Personally, if you know how to take a blood pressure, you can use your stethoscope. If you know how to do it, then I think manual is better, as long as you do it right. Otherwise, it's fine though to use the electronic. There's one thing about the electronic that it might not do. If a person has a heart rate that's irregular, it might not measure the blood pressure properly. And if they have early beats, sometimes it doesn't count the beats, because blood pressure monitors usually tell you the heart rate. So it's not 100%, but it's not bad. So if that's all you got, that's fine. The body position is really important. If you cross your legs, it'll make the blood pressure go up. If both your feet aren't on we say put your both feet on the floor so you don't cross your legs. Your back needs to be straight in the chair. If it's not, then your blood pressure will go up. And when I say go up, I mean, maybe it's a couple points, but if you put all this together, because people don't do that, they just don't do it right. You're not supposed to be talking. It'll make the blood pressure go up a little bit. Rest 5 to 10 minutes. I'm a big proponent of this, because if people don't sit and rest and relax for 5 to 10 minutes, then the blood pressure you take is the one that they needed to have higher when they were walking over to the chair to sit down. So it's going to be a false elevated reading. And you really want to know, what if they have low blood pressure? You want to know that kind of stuff. So if they're on blood pressure medicines, I always say wait at least a couple hours, 1 to 2 hours before taking the blood pressure, because you also want to know what their lowest is and what their medicines are doing. The other thing too is sometimes people get impatient and they let that air come out of the blood pressure cuff. If it is a manual, they'll let that go too fast. So it really should be, we still say millimeters of mercury, but it's not, there's no mercury in there, but 2 to 3 of those, they're not notches either, but the little marks on the blood pressure dial, 2 to 3 every second. That's the proper way to do it. And also what we know from research is that home blood pressures are better because there is such a thing as white coat syndrome. People get nervous, whatever. And so if you teach a person properly what I just talked about, then they'll get a better reading, because blood pressure tends to be about 5 points lower at home. this is what medical uses for the hypertension guideline. I'm not going to talk about what the recommendations are, but this is just to kind of let you know, if you are actually looking at a blood pressure, in the medical community, blood pressure medicine would be started here, but that has to be, you're supposed to look at 3 different blood pressures that were taken at 3 different times, and they need to be elevated over after or over 130. And here this talks about the lower number. So on your blood pressure reading, it'll be a upper number, and that's this SBP, systolic blood pressure, and the lower number would be DBP, diastolic blood pressure. That's the relaxation. That's measuring when the heart isn't squeezing, what is the pressure in the artery. When it is squeezing, that's the systolic blood pressure, because that should be higher pressure than the lower one. It always is. Anyway, so you have all that stuff, all of this here to look at. But for me, if the blood pressure is not taken properly, then you could actually put someone in this stage, because you don't need to do much to do that. I had some questions. A few people asked me, they asked about like, well, when is it too high? When is a blood pressure too low? Well, first of all, if you have capability to check blood pressure and your blood pressure is over 180, especially if you feel bad, like headache, dizziness, vision change, anything like that, you need to go to the emergency room, because they have a way that they can bring the blood pressure down right away. So this would be dangerous. That's dangerous for stroke and that kind of thing. If you were exercising and your blood pressure got up, let's say you're young and you're exercising and you're in your heart rate's in the 170s, or your blood pressure is getting up to 160 or 170, maybe you should back off a little bit, because, why is it that high? But it is temporary. So it's the chronic above 140, 150 that people get concerned about. It's the high of 180 or above that we start to worry about stroke. But below that, it talks about 160 to 180. And if I had someone in the clinic and they're, 160, 170, something like that, if they have their medicine with them, I might have said to them, well, let's just bring it down. And then what I would do is I would go backwards. If they're already on blood pressure medicine, I would go backwards, trying to find out anything in their lifestyle that you could do to make it so that they can reduce their blood pressure and not be on the medicine. Here's a little thing that can be done. We know potassium is positive. It does positive things for the blood pressure, and lowering sodium does really make a difference. So I have talked to people a lot about using this new salt. It's a sodium substitute because it's potassium only. I'll tell you, I've used it. It's not bad, but I don't prefer it on corn, on the cob. But other than that, because it has a bite to it, it's really doable, like on vegetables or meat or something like that. The one thing that you want to make sure is that you don't overdo. So if you're telling someone or recommending something like that, for instance, because I wouldn't just prescribe potassium, because then you do risk of having too much potassium. But you also have that same risk if they use this new salt and then they go like this all over their food and saturate it. I've seen that many times. Oops. And then as far as alcohol goes, it's really the overdoing. If you drink too much alcohol, your risk for heart disease goes up 10%, or not, well, it goes up 10%, but 10% of people that overdo have higher risk of coronary artery disease. The recommendation has been for a long time, 1 drink, and I'm sorry to break this to some of you, but 1 drink for a woman and 2 drinks for a man. Predicting atherosclerotic cardiovascular risk disease. This is a risk estimator that basically it gives you, you can look this up, you can do this yourself, you can put your numbers in, and it will tell you what your risk is over a 10-year period of having an event. An event is, heart attack, or, heart attack usually is what we're talking about. And then as far as lipid testing, so medicine sometimes seems to be about 10 to 20 years behind. And I've been very aware of like the utility of the lipo, different, the nuclear medicine or magnetic resonance testing with the lipo little a, or LP little a, some of that testing. And that's looking at very, very small particles, and they're the ones that tend to get in the heart arteries. So I've known about this since like early 2000s. And there actually was a lipid association, lipid stands for cholesterol, that was using that. It hasn't been used. It's been discussed in medicine guidelines, but there's a lot of utility, and finally medicine's talking about looking at that and then what can be done for it. Let's talk about chest pain. So I was just trying to think, what are some things that could help a person when you have, someone in your office and they have some heart problems? And you don't have to be treating someone. It's good for everyone to know. Basically, if you have chest pain from heart disease, this is referred to as angina. If you've heard of that word before, that just means heart pain from the arteries. But otherwise, chest pain, there's 100 different reasons that you can have chest pain. So it's a little difficult, but there are some common things that are characteristic of heart artery disease or angina. It's basically a mismatch of what the heart needs as far as oxygen and blood and the nutrients. So if your heart has arteries that lay on top of it, and then they get smaller, and then they go into the heart muscle. And the arteries that lay on top of the heart are the biggest parts of those arteries. And those are the ones that we stent. If you've heard of that before, if someone has a heart attack or they have a significant blockage, it's those arteries that get stented, because most of the time we don't have like small enough stents to go into some of those arteries, and the risk is worse than in trying to stent those arteries. So there's a lot of really strict criteria about that. And right now there's a debate about which is better, medical therapy versus stenting. But they've debated that for a lot of years and looked at a lot of the research, but it's a mismatch basically. So the heart wants more, but the heart arteries can't feed it as much as it needs. So that can result in basically a heart attack. There are different kinds of heart attacks. You've probably known of people that had a heart attack and it was like, okay, well, they're fine. And they're out jogging, 3 months later. And then you've heard of people that have a heart attack and then they're gone. And then it's all the way in between too. It really just depends on how much of the heart was affected. So if it's a small artery, there's less of the heart that's affected. If it's at the bottom of the heart, less of the heart's affected. If it's over in the middle of the heart, it might affect your own natural pacemakers. You have a couple places where you have that, and that can cause a heart rhythm problem, especially if the pacemaker portion dies. So anyway, when you talk about, you can see at the bottom, like what are some of the things that would cause cholesterol to get into the heart artery walls? And remember, I talked about getting underneath the lining when the cholesterol comes to actually help. So when it comes to the artery wall, then it can get trapped. Sometimes other things can cause inflammation in the arteries, and it's not from like having too much. I'll give you an example. So like the heart arteries, as the cholesterol is getting underneath that lining and the muscle layer, like I said, for a long time, it's what we call soft plaque, and it's not super stable. But then as time goes on, the heart brings calcium, excuse me, it stabilizes it. Well, there are some other things that actually can have an effect as well. As far as like the inflammation, it says, I have in my slide, environmental toxins. A lot of us know this, some of the things that we get exposed to, and then in addition, heavy metals. So I will talk about this in a little bit. One of the treatments that I've been really focusing on for prevention and also hopefully regression of coronary artery disease, which right now, like the mantra for that has always been you can't regress it. So, and then there are other things too, like these are some of the reasons for inflammation. If someone is like sensitive to certain foods like gluten, or if your gut microbiome, and I was reading as I was doing, some research and getting myself up to date and that kind of thing, that they are finally making some headway in that way as far as the gut microbiome having effect as well, which is very encouraging to me regarding the medical field. So I talked a little bit about the cholesterol getting in between the lining of the artery and the muscle layer. This is the muscle layer. I've seen this on angiograms. I've seen stents put in. They put a balloon right here. If it's bad enough, they don't put stents in unless it's 70-80% blocked or more. And so they'll put a stent in here and they'll squish that cholesterol against the walls. The stent is a metal thing. It looks like chicken wire. They're very small. It's not chicken wire, thankfully. And then it basically is done for relief of chest pain. That is the main reason why they do it. They don't do it to preserve your life because they can get clogged as well. So that's the main reason, is if someone has chest pain and you can't get rid of it. Exercise is very good. If you have someone who has heart disease and they can't fix it with something like that, walking is very good, because the body starts to adapt to the lack of maybe, you're not getting enough blood flow. It starts to adapt, and that's a good thing. What does it feel like? Chest discomfort often is described as aching, burning, and fullness. Can or may not radiate to the arms, neck, or jaw. Or it could be both chest discomfort and shortness of breath. But the main thing that we really notice that's the classic sign is when it comes with exertion, because the heart needs more and it's not getting it. And then it goes away with rest. And it's more stable if it goes away with rest immediately. We like that. If it doesn't, then if it takes a while, that's kind of like, to me, that gives me an eerie feeling. Women don't always feel things exactly like men. Some of that is women have a lot of microvascular disease that's in the small arteries. And especially diabetics don't either. Sometimes they don't have pain because their arteries, or not their arteries, their nerves have been affected by the long time of sugar exposure and the toxic effects of that. So, but for women, they have shortness of breath more often than chest pain, and they get it with exertion and it gets better with rest. But not everybody follows the textbook recommendation, or not recommendations, but the description. So you just have to be willing to let your red flag, recognize a red flag, which is, nobody really should have chest pain and they should be checked out. I have seen this a lot, exertional symptoms. Sometimes people will say they are running out of gas, and I will just ask them, how are you compared to last year or 6 months ago? What were you able to do then that you can't do now? And if they've had a significant decrease in what they're able to do, and there's no explanation for it, and it's in addition to having chest pain or shortness of breath, that's very, very worrisome to me. There's also stable angina, and that's where it's always with exertion, always is relieved promptly with rest. And then there's unstable angina, and that's when you started out with that, but now it's becoming more frequent, it's more intense, and it's coming at rest. That's very very worrisome. I wouldn't, if you are making a referral or something like that, I don't know if anybody is doing that, but if you did, I would make sure that it's like within a week, if not sooner. Basically, sometimes people don't know what a heart attack is. So a heart attack is when you have this cholesterol that is so much, and then as the blood, this is like over time, because it's a year's progressive thing. Most of the time, it takes a long time. But then when you have this small area that the blood's getting through, a random blood clot can come through there and and block it. But also, if you have too much cholesterol, you can like have what we call, it's we don't call, I can't even think of what we call it, but because it's not a common way to describe it, but basically there's inflammation there, and then to me the way I describe it is the dam kind of bursts, and you'll see like cholesterol having traveled downstream from that area, but also you'll see the blood clot that forms there because it's now coming to band-aid that injury. So what if you're with someone and they're having crushing chest pain? I would give 4 baby aspirins and call 911. If you had oxygen around, that's good. I would use that too. There's more for a person to do, but this is just like if you're in that situation. I added a couple other things because we've talked about hypertension and we've talked about coronary disease, but I think these are common things that people complain about. And if you have clients and you're assessing it, or if you are at home and you're having these symptoms, there's a difference between lightheadedness and dizziness or vertigo. You've probably heard of vertigo. Vertigo is when the world is spinning around you, and usually dizziness is kind of like that too. So those are just two words that to me are kind of interchangeable. But lightheadedness, lightheadedness is basically when you go from seated to standing. And one time I was teaching CPR classes and I was bent over the mannequin of all things. So I'm doing the CPR and then I'm up and I'm explaining to the students, and then I'm down again and then I'm up again, and then everything went black and I almost fainted. All that is that the blood pressure didn't have enough time to rise up high enough to my brain. Sometimes people have it because of medicine. Sometimes they have it because in people with Parkinson's is very, very common because their nervous system isn't as good at telling the arteries to get tighter so that the blood pressure stays higher. So a lot of reasons for it. Dehydration is one of the most common things. And so in that case, if they don't have heart failure problems, I would have them drink more. 64 ounces a day is a good recommendation. And then some people have other recommendations. Vertigo is often like inner ear problems, inflammation, wax in the ear. Labyrinthitis is like one of many inflammatory things in the ear. It's just where the tubes back there get inflamed, and it's awful. Swelling. Let's say somebody comes in to your a client of yours that you're working with, or if you're having this kind of a symptom. In general, if it's in one leg, and especially if these conditions have occurred like a long period of time where the person wasn't moving their legs, elderly, history of blood clot, being on like birth control pills or something like that. And then you get like one leg that's swelling and you have some pain in your calf, not always though, or some redness or heat to the back of the leg, that would be a sign of maybe a blood clot. That's really important. Some people don't realize that if it's one leg only, it's more likely that, and you would need to check that out like right away, because if it breaks off, it can go up to your brain and cause a stroke. If you had both legs with shortness of breath, I would be more worried about heart failure, because when you're looking at that heart and the arteries and the veins, if the heart isn't keeping up with the fluid for whatever reason you have more fluid on board, if it's not, then you would have a backup of the fluid down below. And so usually it'll be both legs. And then especially if they have shortness of breath at night or when they lay down. There is also the possibility that if they have a lot of varicose veins, that their veins have just swollen and then they have a lot of fluid left in their legs. In that case, I would usually recommend like compression stockings, 20 to 30 weight. And that's actually how they're treated for 3 months before anything would be done. Does anybody have any questions?
I think I'll chime in here first. Wow, that was absolutely fabulous. That was a plethora of great information. Thank you so much for your time and effort to educate our audience. I think my favorite part was when you mentioned that if there's cardiovascular disease in one area of the body, that likely it's elsewhere too. I think that's so important. And and not often mentioned or discussed. So like she mentioned, if there's any questions, we've reserved some time for that. You're welcome to place it in the chat, or you're welcome to raise your virtual hand and we'll call on you. Just let us know.
Hey, Tracy, can I
Yeah.
talk?
Yeah.
Okay, just wanted to make a comment, when Dee was talking about, A1C and its relationship to cardiovascular risk. One thing that people don't really understand about A1C measurement is, what are you measuring? This is actually a measurement of what's called advanced glycated end products, AGE. Now, what this is a measurement of sugars that have become oxidized due to free radical damage. Now, in this case, yes, this is a measurement of the time that sugars have spent in your bloodstream. They've had a chance to get oxidized. It's not just what you ate today, it's what you've eaten and how you've managed your sugar for the last 3 months or 3 weeks, whatever. It's a good measurement. But if we're measuring advanced glycated end products and it's relative to your free radicals, this is making a big assumption that everyone has the same free radical level of damage going on in their body. There are people who have tremendous amounts of toxins in their body, tremendous amounts of metals and chemicals that would oxidize their sugars faster. So with normal sugar amounts, they can still have a high A1C due to excessive oxidation. So there's people who are saying, why is my A1C so high? Check metals, chemicals, other versions of toxins, or oxidative processes that can happen outside of that, like liver problems, kidney problems. And then go back to what Dee's commentary was about, well, then why is there high cholesterol in a localized area? Because there's metals and chemicals lodged in that cardiovascular tissue. So there's a connection between those two conditions. There's damage to the tissues due to free radicals that makes excess cholesterol to go into that place, and then also would increase their A1C, furthering their cardiovascular risk. And so with numbers that are reasonable, they can still have double the problem based on those two numbers.
Thank you. Oh,
That's
sorry,
right.
go ahead.
I just Dee asked me about the cholesterol level and the lipid profile in general. I understand you have to give statin to your clients and patients based on your background. I always say, do not stop any medication your clients are taking or patients are taking until you start seeing really a huge difference in the numbers and the lab results. What we do takes time to make the difference. Omegas are amazing, walking and exercise is amazing, vitamin D3, as Dr. Essen said, minerals. We always highlight the minerals. It's very important. But again, you do not stop the medication. You keep them on their medication until you see really good progress, and then you start tapering down their medications.
Beautiful. Thank you for
I
that.
have a question on that for Dee.
Go for it.
So Dee, I see a lot of clients come in and they're on statins, and they want to come off. They don't like the effects. They don't like how they're feeling. I would never take them off, just like Abid just said, but they go back to their doctor and they never get off of them. So my question is, are you guys trained to like never take people off, or like what's that protocol for you guys?
Yeah, so like I think the protocol is, and some people take, so from a cardiology perspective, I would tell you what that is. And that is that, especially because people are living longer, they really are into their 90s and they're living alone, that they would keep the statin as long as it's not doing anything as far as side effects. Now, for me, I always was like, we would just have a discussion and I would just say, well, this is why it's recommended. And this is the data that supports it. Basically, I would just say fewer heart attacks and strokes. I do know people that had good success with it, but what I would say is if someone had side effects and it's affecting their quality of life, then I would, if they wanted off, I would let them off, because they're just, it's a risk. Like, how much is the risk really? Everybody's different and they have a bunch of different, they have different genes, they have different lifestyle, they have different exposures. And so when medicine is one size fits all, it doesn't really work that well that way. So anyway, but yes, in general, there have been some people that would take them off after 80 years old, but I had a patient he didn't have any problems, and then he was 101, and then he had a heart attack. And then he found out he needed bypass, but he couldn't have it because he was 101. But so in his case, then he got a statin at that time. So he was mad about it too. So I didn't give it to him. I didn't give it to him.
Thank you.
Because I wouldn't, if I was 101, I wouldn't take it. Can I say something really quick I forgot to talk about? And that's I talked about like the calcium in the heart arteries. There's a test called a calcium scoring test that I think it can be very helpful, especially if you have a big risk factor, a risk factor as a family. It is very low. Like you do need to be concerned if you've had a lot of radiation, for instance, but in the whole amounts, at least that is said is okay. It's super low, but I've worked with a physician out in, I'm collaborating, and he's in New Jersey, and he has got some really nice data with using chelation IVs to try to pull out some of that calcium in the arteries. Anything over a 0, you shouldn't have anything over a 0, but they say definitely over 100, that's a positive test. And so he has seen differences over a year, 2 years of using chelation therapy to pull out the heavy metals, including the calcium, and he has seen a drop in numbers, on average 400 drop. So when I say I'm collaborating with him, I'm just going to share my data, but so I don't want to make it sound bigger than it is, but I'm just super excited about that, because literally we've been saying for years, they've been saying, whoever, that you can't regress coronary disease. And I'd really like to see about this. But the one thing you have to remember about that coronary calcium scoring test is it doesn't say anything about the soft plaque, and that's the more vulnerable plaque. But imagine if you have, sometimes these arteries get so calcified, they're so stiff. If you can get rid of that, then the artery can work, because it can't tighten, it can't relax very well if it's all stiff like that.
Thank you. So this maybe is a question for any of the members of the board as well. Are there any ancillary services or therapies, either including or not including supplementation, that you might recommend to help increase circulation or be preventative as well? Anybody can chime in.
Well, as Dee mentioned, chelation is very important. But when you do the chelation, you need to go to people like Dee. I'm not trying to advertise for you, but because it's you have to make sure they're doing it right. They give enough minerals before they start the chelation, because it's not a joke when when you move these metals from brain to somewhere else or from kidneys to. So you need to do it right. You need to make sure the kidneys are working good before you do the chelation. So chelation therapy is something you can do on the top of supplementation as well.
And I've seen that there's a number of herbs that do tend to stabilize the heart rhythm and strength and enhance the distribution of blood. That goes anywhere from like hawthorn berry, gotu kola, ginkgo biloba, nopal cactus, black pepper extract and black pepper essential oil. Actually also ylang-ylang essential oil, clary sage essential oil, orange essential oil will do a good job of that. And that can be localized. If it's a topical localized area of poor circulation, that can be used right on the skin to enhance that. Cypress also does a good job there. We should also mention that there's the mechanism of nitric oxide. Nitric oxide synthase is how you control the contraction or dilation of blood vessels. And there's a number of things that can influence that. That's kind of a whole webinar in and of itself. But there are some things out there that help nitric oxide, but do not attempt to raise nitric oxide levels by taking large amounts of arginine or beetroot powder. Those things actually cause as much damage as benefit. You need to be very careful about that aspect, but when it's done correctly, nitric oxide can make all the difference for not only blood pressure, but overall blood distribution, because it's softening the arteries and decreasing inflammation. At the same time, it regulates the contraction dilation.
And we're almost out of time. So really quickly, PEMF, what that does for circulation is incredible. We actually have slides in the office of the blood, and it's like stacked, you know, like a roll of quarters. And after one 30-minute PEMF, it was all free flowing like it should be. So that is incredible for circulation.
Thank you so much. So that being said, thank you everyone for taking time out of your evening to be with us. We greatly appreciate it. If you're not already aware, the International Holistic Health Alliance, aka IHHA, offers these amazing monthly webinars on the last Tuesday of each month at 7 p.m. Central Standard Time. If you're not already on our mailing list, please reach out to us. I put our email in the chat. We'll add you so that you don't miss any of the amazing events that we have going on. In early spring, we haven't exactly honed down the date yet. It's either going to be the last week in March or the first week in April of 2024. We're going to be hosting a retreat in Nashville, Tennessee that, trust me, you do not want to miss. So plan ahead now, reserve both of the weekends until we hone in the exact date. We'll have more details on those in the upcoming weeks. And lastly, if there's any topics that you'd like us to delve deeper into, please feel free to either email us or list it in the chat. We want to make sure that we're bringing the topics and the education to you that you really want to learn about. That's the main goal of the IHHA, is to bring you the very best natural health education so that you can be preventative in your own health and wellness for yourself and your families, that you all can have vibrant health, energy, and vitality. So thank you very much. Enjoy the rest of your evening.
Thank you.
I think I stopped it. Nope, I didn't.